In relapsed refractory multiple myeloma, we currently have many solutions because second generation new drugs have been tested in combinations with other drugs, and it turned out that these new combinations are very effective. The problem is that they are very expensive. So in some countries, they are not even available, and cost questions are becoming a key issue when deciding the treatment of a patient with relapsed multiple myeloma. There are countries in which you cannot prescribe the best combination, and you are obliged to use an algorithm to try and define which is the best after the one you would have chosen. For instance, in a patient with lenalidomide naive or sensitive, you can choose a combination with daratumumab, lenalidomide, dexamethasone, which is probably the best. But if daratumumab is not available, then you have to test or to try and choose carfilzomib, lenalidomide, dex, or ixazomib, or elotuzumab. But there are countries in which these three agents are not available as well. So you have to go to the classic Velcade, Revlimid, Dex. So that is the first point. In some country, you cannot choose the combination you would like to choose. In other countries, all combinations are available, but you still can consider that cost effectiveness is important. And there are some studies, rare actually, which can try to understand what is the cost related to a given benefit. And that could help doctors in choosing their treatments. Unfortunately, these assessments of cost effectiveness are not that easy to understand for a physician. And their main use is for payers, like in UK, where the cost effectiveness assessment is used for registration of the new drug. In other countries, you can just have an idea and, for instance, decide to use the most expensive drug for the treatment of second relapse, because the treatment will be shorter, and use a less expensive drug for the treatment of first relapse. That is possible when the new drugs doesn't confer an overall survival advantage. So if there is only a progression-free survival advantage when using it in first relapse, then you can choose to use it in second relapse. So these are cost effectiveness considerations. And I'd like to finish by another one, which is maybe for the future, but for the key opinion leaders who are in charge of designing new protocols. Until now, we have decided to compare one drug versus another, and we have never addressed the question of the duration of treatment. And the problem with this new agent is that they are very expensive, but they are prescribed for a long period of time. In the past, it was necessary. You prescribe a treatment for a relapsed patient until the next relapse. But now, since the results are so good, you can address the question of the optimal duration and maybe design randomized trial testing the classical strategy until next progression, or a limited period of treatment if the patient responds well. That is another way of using the question of cost effectiveness.